सिस्टम के बारे में हम सीखोगे कि डाइजेस्टिव सिस्टम के कैसे कोडिंग की जाती है और क्या चीज़ें होती हैं। आपको समझ आ आएगा कि डाइजेस्टिव सिस्टम और गैस्ट्रो कोडिंग कैसे की जाती है ताकि आपको ये सारी चीज़ें समझ आए। So we'll start my screen is visible. So once please confirm that. So so now I will start on the presentation so you can understand. Gastrosurgery training for the colonoscopy. So first we know that the colonoscopy examination, that is a colonoscopy examination of the entire colon. Colonoscopy is a examination of an entire colon from the rectum to the cecum and may include the examination of terminal ileum or small bowel, proximal and entamosis. So this is a colonoscopy, right? Rectum to the cecum. If the scope is reached, that time it is considered as a complete colonoscopy. Colonoscopy through the stoma. Colonoscopy through the stoma. What is a colonoscopy through the stoma? If question is coming, so you'll understand the examination of the no, light on examination of a clone from the colostomy stoma to the cecum or colon small intestine. Anastomosis may include examination of ileum, terminal ileum or small intestine immediately proximal to the anas- anastomosis. Okay, so this is a two kind of a colonoscopic procedure is generally performed. First is from the natural openings, so via natural openings. Second is going via the stomata, through the stomata. So there are type of the scope that are rigid colonoscopy or rigidoscopy and flexible. So this is a kind of types we'll explain in detail in the next slide. Scope entry, transanal. So colonoscopy or like scopy procedure is generally performed by the natural approach. So you'll see here the transanal and second is colostomy. So here example is given for the like a diagnostic colonoscopy. If you will see the anatomy of a large clone that is anus rectus sigmoidal clone, then you will be see the descending clone, left colic splenic flexures, transverse clone, and right colic hepatic flexures, ascending clone, cecum, appendix, right? Or ileum you will see here. So if scopy is inserted till the descending clone, that time we are coding a sigmoidoscopy. If it will cross the splenic flexure and reach to the transfer clone, that time procedure is performed only here. We are using the colonoscopy with a 53 because of like diagnostic procedure. If the colonoscope reach to the cecum, that time we are coding with a 45378 as a complete colonoscopic procedure. Sure. I hope this slide you will understood. If you have any question, any concern, please comment. So next question is here, what type of scopy is it? So you will see here the visualizing scope types is a rigid scope is here given that anoscoscopy for proctoscopy. So you will see here these all type of the scopes. Flexibles, you are seeing here flexibles. Example is here sigmoidoscopy, colonoscopy. So the first detail to consider the purpose of the encounter. Colonoscopy fall into the four basic encounter provided to the patient in the absence of sign or symptoms. So here given that a few pointers like as screening colonoscopy, diagnostic colonoscopy, therapeutic colonoscopy, surveillance colonoscopy. So what is the difference between these colonoscopic procedures? So we'll discuss about that screening colonoscopy. So what is the screening colonoscopy? Patient, in absence of a sign and symptoms, is provided a history accordingly. Patient provided like a history, medical guidance, and it is a population on which the test is performed, not result of any finding test such as the described colonoscopy, the routine performed asymptomatic person. Like screening is colonoscopy is when performed when the no symptoms, no procedure, no symptoms, no conditions are there, only for the examination purpose or general awareness routine checkup. That time we are using a colonoscopic procedure. Diagnostic procedure is performed when the patient has a physical symptom such as the pain, and the test is a necessary to either rule out or confirm or suspected condition, sign and symptom used to explain the reason for the test that comes under a diagnostic. Therapeutic is performed when the abnormalities are treated for the biopsy, tumors, ablation or other therapy. Surveillance colonoscopy is when the patient is asymptomatic but has a personal gastrointestinal disease, clone polyps. Technically, this is a screening test which different of the coding and frequency guidelines. So these all points you will see here. Please let me know if you have any question, any concern. So I will discuss in the next coding guideline here. Okay. If you have any question, feel free to ask this. So I will explain in detail. So next, coding guideline. Coding guideline diagnostic endoscopy is included in a surgical endoscopy. So you will see here the
So you will see here now. So you will see.
diagnostic endoscopy is included in a surgical endoscopy. Code for the highest extended of a scopy based on the scope entry site. For example, if physician perform procedure proctoscopy, sigmoidoscopy, and colonoscopy, code all procedure as a colonoscopic procedure. If multiple polyps are, second guideline is here, if multiple polyps are removed by the same techniques, use one CPT unit only. For instance, one polyp was snared and three polyps were biopsy with a cold biopsy forceps. This service would be reported with a 45385 colonoscopy with a removal of tumor or polyps lesion by a snare technique, and 45380 colonoscopy with a biopsy procedure. So both procedure will be coded together. Next guideline is where ECD and colonoscopy performed during the same session do not require 59 modifier on either procedure as they are not bundled together. Biopsy or a polypectomy performed in a separate site are reported with two codes. The biopsy codes are used 59 modifier. Okay, so please take a screenshot. If you have any doubt, any questions, you can see, you can ask that. Next guideline is if the intent of colonoscopy is for the screening and polyps or lesion is diagnosed and treatment is performed, then colonoscopy is billed as a surgical procedure and two diagnoses should be used. In this example, report ICD code for screening colon cancer as a primary diagnosis and polyps as a secondary diagnosis. So in this scenario, if like a screening procedure is performed and that is a change to the diagnostic. So that time we are coding two ICD code. One is a screening code, second is a polyps or therapeutic related code. Do not report control of bleeding as a result of endoscopic procedure during the same session separately. It is a bundle with the primary procedure. For colorectal cancer screening, use G0104 to G0106 and G0120 and G0122. We'll discuss about this code in a detail in a next slide. Read the parenthetical instructions that are given below CPT codes carefully to identify the procedure that are excluded and included. So you will see these all guidelines. So this will help into the digestive post coding and gastrointestinal coding system. An overview of colonoscopy coding guidelines. A screening colonoscopy is a service with a first dollar coverage, no copay or deductible from the patient. But what if the surgeon take a biopsy or removal of polyps? So in that scenario, what we will think? Please comment. How is that built and with what modifier you will diagnose? Or append how to code the screening colonoscopy, what a modifier are needed, and what a diagnosis codes to be assigned. The changing the surgeon's things. So these all kind of questions generally coming when you are doing the gastro coding. Okay, so you will see into these all questions answer in this video. So you'll able to answer those things. An area of the particular confusion, screening colonoscopy converted to diagnostic or therapeutic colonoscopy. Too complicated, the issue Medicare use different procedure codes and other payers for the screening is a different modifier for a screening procedure that's become diagnostic or therapeutic. So we'll discuss this all kind of scenario in our next upcoming slide. So you'll get understood. The next question is coming a difference between a screening versus diagnostic colonoscopy. So what is the difference between the screening or diagnostic? A screening test is a test provided to the patient in the absence of sign or symptom based on the patient age, gender, medical history or family history according to the medical guidelines. It is defined to the population on which the test is performed. No other result of findings or test, such as a screening described the colonoscopy is routinely performed on the symptomatic person for the purpose of testing for the presence of colorectal cancer or colorectal polyps. Whether a polyps or cancer is ultimately found does not change the screening intent of the procedure. Diagnostic procedure is a test performed as a result of abnormality finding sign and symptom. Medicare does not waive off the copay and deductibles when the intent of visit performed as a diagnostic colonoscopy. Medicare waive off the deductible but not copay when the procedure is scheduled as a screening is converted to diagnostic or therapeutic procedure. So especially Medicare having a different guideline, so you will get that Medicare does not waive off the copay or deductible when the intent of the visitor perform diagnostic to colonoscopy. Medicare waive off the deductibles, but the copay when the procedure scheduled as a converted to diagnostic to therapeutic. So these all guidelines are mainly related to Medicare. So you will understood as per the peer things. Difference between the screening and colonoscopy still we are going. So let's see the examples, live examples. So this will be help you. So you'll read in their slide. If you have any questions, please comment it. So in these questions, screening colonoscopy is a preventive procedure to examine the colon to ensure it is a healthy. All adult 45 and older need to screening because colon cancer is one of the most common and deadly cancer. Cancers, it is also typical treatable when it is a catch early. Better yet, a colon cancer can be prevented by findings and removing a polyps before they can develop into the cancer. According to American Cancer Society, people with average risk of developing colon cancer should have a screening colonoscopy every 10 years. So if any healthy patient, they are going to the screening purpose, if they are taking a screening part, they will understood the things. Okay. So each and every 10 years, if the colonoscopy procedure performed, so they will find out like in during if any abnormality, any cancers, any polyps will come, so they will be found. The colonoscopy is a consider a screening when you had no longer gastrointestinal sign symptoms before the colonoscopy. No polyps, no mass are found during the colonoscopy. There are no family history of the polyps or colon cancer. You should have you have no history of the polyps or colon cancer. So if there are three pointers like there is no sign and symptoms, no polyps, no family history, no personal family history, colon cancer, these kind of things, no, not there. So that time screening will be performed. So, key benefits and guidelines of preventive procedure for the healthy adult 45 plus. It is typically treatable when the catch early and the colonoscope cancer can be prevented by the findings and removing the polyps before they develop. American Cancer Society recommendation. People with the average risk of developing colon cancer should have a screening colonoscopy every 10 years. Classify as a screening when the recommendation all criteria must be. First, no lower GI symptom before the procedure. No polyps marsh found during exam. No family history of the polyps, colon cancer. No personal history of polyps or colon cancer. So this will be considered as a screening. This is examples like colonoscopy is a considered diagnostic when you have had a sign and symptom in a lower GI tract noted in your medical record before the procedure, including the abdominal pain that does not improve, anemia, change in bowel habit, constipation, diarrhea, rectal bleeding, blood in a stool, polyps with the 10 years, within a 10 years, a positive stool based the case CT, colonoscopy and required the follow-up colonoscopy, rectal bleeding, blood in a stool, polyps within a 10 years. These all points is the importance. A positive stool test or CT colonoscopy and required a follow-up colonoscopy. So these all pointers will be helping to the known that this is a diagnostic. Screening colonoscopy structure codes Medicare versus non-Medicare code structures colonoscopy. 45378 are colonoscopy non-Medicare standard, right? So you will be if the like no, screening is performed and that is non-Medicare, so you will use a diagnostic purpose 45378. If the Medicare colorectal cancer screening colonoscopy on the individual at a high risk, that time we are using G0105 for Medicare high risk. For Medicare average risk, we are using G0121. Colorectal cancer screening colonoscopy on an individual not meet the criteria for the high risk. Diagnostic coding for the colonoscopy. Diagnostic coding for the screening colonoscopy. Common ICD code ICD-10 diagnosis for the screening. High risk criteria. You will see the high risk criteria, close relative family history, personal eligibility history. So this kind of point you need to code. Medicare considered as an individual at a high risk for the developing the colorectal cancer if they have one of the more flowing cancer like inflammatory bowel disease, including Crohn's disease, ulceritis. This kind of examples condition are there. Those patient having a high risk of the criteria. Close relative, a close relative, siblings, parents, children who has had a colorectal cancer or the adenomatous polyps. So please remember adenomatous polyps is there. That time chances are there of the cancer related polyps, right? A family history of the familiar adenomatous polyposis or hereditary non-polyposis colorectal cancer. So this kind of like examples or diseases suffer from your family, that time it comes under the close relative family history. Personal history and eligibility. A personal history or eligibility of the adenomatous polyps or colorectal cancer. Medicare beneficiary at high risk are eligible once every 24 months. So 24 month time duration is there. So beneficiary at a high risk for developing colorectal cancer are eligible once every 24 months. So these all points we discussed in the things. Medicare coverage, standard screening every 10 years, high risk screening every 24 months. High risk criteria, history of the polyps, colon cancer, family history, personal IBD, and history. Diagnostic colonoscopy, Medicare 20% of the coenzyme and applies. So this is the guidelines for Medicare. Screening colonoscopy, high risk criteria, diagnosis coding, high risk colon targets area. ICD code is a UJ85.038 as a personal history of the other malignant neoplasm of the large intestine. Z85.048 personal history of other malignant neoplasm of the rectum, rectosigmoidal junction and anus. Z80.0 is a family history of the malignant neoplasm of the digestive organs. Z86.012 personal history of the chronic polyps. So these all ICDs are used of the colonoscopy coding. Screening of the colonoscopy modifier is there. The modifier PT for Medicare insurance. So you will see here converted indicator. CMS developed the PT modifier to indicate the colonoscopy that schedule as screening was converted to diagnostic or therapeutic procedure. PT appended to CPT. The PT modifier colorectal cancer screening test converted to the diagnostic test or other procedure appended to the CPT code. Example addiction added PT add modifier PT to the CPT code above indication that scheduled screening colonoscopy was converted to diagnostic or therapeutic. Anesthesia service inclusive modifier PT should be the added to the anesthesia service as well as financial impact informed. This informed the Medicare that its service performed for the screening and the patient will not charge deductible. There will be copay due. This point is the main. Screening colonoscopy non modifiers like you will see here ACA and documentation. Documentation intent surgeon must documented a screening intent for the claim processing without out of pocket expense under the ACA. 33 modifier definition for the preventive service with the USPS TFA and B ratings identify the services by adding 33. Clinical example scenario screening colonoscopy converted to the polyps removed via the smear action use CPT 45385 append the modifier 33 screening and polyps removed bill the 45385 plus 33 modifier. Common diagnosis for the colonoscopy colorectal cancer is there clonic polyps extra tissue growing in the colon that become the cancerous, that is called adenomatous. Ulcerative colitis, ulcer of the colon and rectum. Diverticulitis, inflammation or infection of the Coaches in colon, irritable bowel syndrome, an uncomfortable condition causing abdominal cramping or other symptoms, Crohn's disease, valvus, mega colon or fistula, intestinal obstructions, malignant neoplasm of intestine, iron deficiency anemia, colitis, gastritis, diverticulitis, bowel syndrome, and Koch's irritable bowel syndrome. These Crohn's disease, all these conditions are related to digestive system. Colonoscopy code set you will see here. Colonoscopy is screening, diagnostic, removal, dilation, submucosal procedure, evaluation lesion, ultrasound procedure, or other procedure. These are classified. If I'm coming to the screening part, high risk 10 G0105 not meeting criteria for high risk, G0121 and with a barium enema G0120. Diagnostic if there 45378. If removal, foreign body removal 45378 CPT code used, biopsy single or multiple 45380 CPT codes are used. Lesion by the hot biopsy 45384 and lesion by the smear technique that time 45385. If the colonoscopy performed for the dilation ballooning, so 45386 dilation and stent 45389. Submucosal procedure injection is given 45381 or resection EMR is done that time 45390. Ablation lesion, colonoscopy with ablation lesion is there 45388 and ultrasound procedure limited to the Syncom 453891 ultrasound for guidance FNA that time we use a 45392. Other procedure like a bleeding control, we have a CPT code 45382, a placement of the decompressions tube 45393, band ligation, we have a separate code 45398. So these are a CPT code mainly used for the colonoscopy set. Colonoscopy through the stomata, screening, diagnostic, removal, dilation, sub mucosal procedure, ablations, and ultrasound procedure are others. So you'll see here high risk in a screening section 10 G0105 not met the criteria. Same code will be used G0121 and with variant G0120. Diagnostic code for through the stoma you will use for 44388 removal of foreign body 44390 biopsy single or multiple 44389. Lesion of by hot techniques 44392 or lesion by smear 44394. Dilation that time we have a code 44405. Dilation and extent 44402. Submucosal procedure injection given that time 44404. Resection EMR that time 44403. Ablation lesion removed that time 4401. Ultrasound guidance limited to the SICAM that time we use 44406. Ultrasound guidance with AFNA 44407. Bleeding control 44391 or placement of the decompression tube 4408. So these all codes are depends upon the natural opening or stoma. Stoma is an artificial opening created by the physician. So this is a very important decision tree. You will understood that tree. How is it? So you'll get this all point. Use of 52 and 53 modifier. Colonoscopy through the stoma. Diagnostic 44388. Colonoscopy through the stoma. This is a colonoscopy through the stoma. So before we are going the natural. So you will see this all point. I believe that I was explain this, but I will explain you in detail. Colonoscopy through the stoma, diagnostic, therapeutic, or colonoscopy through the natural or if so, you'll see here diagnostic and therapeutic. If it will be opening, colonoscopy pass through the artificial opening, so that time diagnostic performed. So we use a scope not reached to the cecum, that time use 44388 53. Scope reach cecum colonoscopy 4390 से लेके 4344309. Therapeutic Not a scope, the scope not reached to the CCOM. That time we have a CPT code, a colonoscopy with a modifier 52 443 This is for the therapeutic scope reach to the CCOM colonoscopy. That time we use a complete colonoscopy CPT code. For the like natural opening, diagnostic procedure perform scope not reach to the splenic fractures. Diagnostic sigmoidoscopy will be coded. That CPT code will be 45330. If the scope passed beyond the splenic fracture and not reached to the cecum, that time we use a 45378 or modifier 53. Scope reached to the cecum, we use the 45378 for the diagnostic part. Therapeutic, if a scope is not reached to the splenic flexure, you sigma we code use sigmoidoscopy code range, and scope pass through the splenic flexure and not reach to the cecum, we use a colonoscopy procedure with modifier 52. Scope reach to the cecum, and then we are using colonoscopy procedure. So guys, do you have any question as of now? If you have any question, please let me know so I will discuss those points. Question will come here, so many questions are there, we'll discuss there, so this will be make you understood. One question is here, scenario one. A 70-year-old Medicare patient calls for the surgeon office requested a screening colonoscopy. The patient previous colonoscopy was in at 59-year-old wasn't normal. The patient has a history of polyps, and the patient children has polyps clone, and the patient is eligible for high risk screening colonoscopy. Answer is here G0121. Rotationally of this scenario, screening colonoscopy for the Medicare patient identified as a non-high risk for the development of the colorectal cancer report with a G0121. Patient has no history of the polyps, but are not confirmed as a adenomatous polyps. So that's why they coded a non-high risk. Similarly, this is the second history of the Crohn's disease and present for the screening colonoscopy. Her most of the recent screening colonoscopy was 25 months ago. No abnormalities are found. Reportable procedure. So you will see here G0105 rotational screening colonoscopy Medicare patient identify high risk of the history of the Crohn's disease. As per the coding guideline, it support for the G0105. Answer Z 12.11 encounter for screening for the malignant neoplasm of the clone, and key 50.80 Crohn's disease for the both small and large intestine without complication. So this way we are coding these things. This is the second scenario, fourth scenario. We will see this all kind of scenario, so you will understood that what is a colonoscopy. Gastrosurgery trainings, digestive system related, you will understood what is the endoscopic procedure is. Esophagoscopy codes are there. There are guidelines related to EGD. EGD is a test examines of the lining of the stomach and the first part of the small intestine, duodenum. During consideration, then you have to check the other things in the scenario like dilation, other band, ligation, etc. is the appropriate code will select accordingly. Modifier related, we discussed that. RCP, endoscopic retrograde cholangio pancreatography guidelines will discuss this. All those points you will see here. Appendectomy in the digestive system guideline decision flow. Code to appendectomy determine the procedure. Laparoscopic code is 44970. Open procedure here. Appendix is a rupture. Code is there 44960. Appendix is not rupture. We have a code 44950. Proctosigmoidoscopy guideline here. So you'll see these all guidelines. We'll discuss in detail this kind of coding guideline. So you'll understood what is a Anoscoscopy digestive system. You'll see this all point. Hernia repair in digestive system. Endoscopic procedure, gastroscopy, gastrojejunums, aliens. This way, you will be colonoscopy related code range. You will get this point esophagus. So this is a general guidelines you will be seeing this slide. So if you want any kind of suggestion or any any procedure, anything you wanted. So we discuss in detail laparoscopic procedure, minimal invasive surgery, so fibratic, this kind of procedure you will be understood. So that's all for today in a live session. If you have any question, any concern related to gastrocolonoscopic surgery, you will reach to me and you can connect with me. So thank you for watching my channels, and I hope you like this kind of technical videos and coding related guidelines. Thank you.